Hi, my name's Ian Battersby. I'm Head of Internal Medicine at Davies Veterinary Specialists. Welcome to our Davies Out of Hours podcasts. And as you know, we're doing a short series focusing on infectious disease. Hopefully, you've already heard the ones on leptospirosis and Leishmania and Babesia. And today we're going to focus on Ehrlichia. And I'm going to be joined by my colleague, Patricia, who's a fellow medic at Davies. As you can see, the setup's a little bit different to our normal out of hours. We're adapting because of the COVID lockdown. The practice, just like your practice, is adapting to remote consults and, obviously still providing advice like we have done in the past. But we're obviously, trying to provide as many different avenues to keep in contact with you. And the podcast hopefully will be informative. So we should say hello to Patricia. Hello. Patricia.
Hello, everybody.
Hello. Haven't seen you for about a week now.
Yes, I think it's a week.
Yeah. I've grown a slight beard, working on a beard for the lockdown. It's showing grey hair. How about you? Well, not growing a beard. That's
well, thankfully not growing a beard.
Okay.
Grey hair, definitely.
I know. Well,
but
all these changes. Right, Ehrlichia. We should. We'll probably follow a similar format to what we've done with the other podcasts, where we do a little bit of background basics and stuff. So Ehrlichia, what species of Ehrlichia is probably the best way of starting off? Do we see in Europe? Because them are the cases that we're going to see predominantly, I guess.
Yeah, so in Europe, it's mainly Ehrlichia canis. I'm not aware of any other species having been reported in Europe causing clinical disease in dogs. So it's Ehrlichia canis.
Okay.
Really.
And I guess just for clarity, I mean, Anaplasma's a different organism, really, in essence. But in the UK, sometimes it might become a little bit confused where we kind of think they're closely related, aren't they? But there are differences, I guess.
Yeah, no, for sure. They're two completely different organisms. We do have Anaplasma phagocytophilum is endemic in the UK. It's transmitted by Ixodes ticks, which we do have in the UK. They're kind of our common ticks in the UK. So we do recognize Anaplasma phagocytophilum as a prevalent disease in the UK. Interestingly, causes some similar clinical signs to Ehrlichia, although the course of the disease can be quite different in that Anaplasma usually causes a self-limiting disease that quite often will not require treatment. So it's possible that some animals will have anaplasmosis and we never identify or diagnose them because they just get better on their own. Whereas that doesn't seem to be the case so much with ehrlichiosis.
Okay. So coming back to Ehrlichia then, just reviewing some of the, it's always important to understand the life cycle of any infectious disease. How is it transmitted?
So it's transmitted by a tick. So it's a vector-borne disease in that sense. And it's a tick that is not endemic to the UK. So it's Rhipicephalus sanguineus, which is endemic to kind of southern European countries, but it's moving north for different reasons. Climate change probably plays a role. But also it's a tick that's very able to live indoors. So, for example, in kennels where there are lots of dogs, a warm environment, humidity, that can be a perfect environment for a tick, and Rhipicephalus can survive like that. I don't know if you remember the tick project that was carried out
at Bristol.
Yes, so in that survey where they collected ticks from all over the UK, they did find Rhipicephalus in some of these dogs. They had all the dogs, as far as I recall, the dogs where it was found were dogs that had travelled. Is it a tick that we have in the UK? Probably not, but it is a tick that can survive here. And proof of that is that these dogs were still carrying these ticks, and therefore there is the possibility of transmission in a dog that hasn't been abroad. So I don't think we should think of Ehrlichia as a disease that we should only think of in dogs that have been abroad, I think we should also think of the possibility that we might encounter dogs here that haven't travelled and have.
So that's interesting, because we talked a little bit about Leishmania, and there's cases of Leishmania in dogs that haven't travelled, and initially there was a theory it might be the flea, but with Ehrlichia, it looks like it is possible for a dog to travel here. The ticks survive in a central heated house, and then potentially that tick infect an in contact dog. So that's certainly a different scenario. Okay.
And also in kennels, for example, or rescue centres that import dogs from abroad and maybe have them in kennels for some time. That would also be a place where you might encounter.
And I suppose that opens the question that, I'm just thinking off the top of my head now. I mean, not for, say, Babesia, because that tends to be more of an acute disease, but in any dog that's rehomed, with an unknown history. I mean, it may have travelled, but it may have come in contact with a kennel where there was another dog with the disease. That should be not our first line part of our minimum database, but we should always have it on the back of our minds now.
Yes, I think in a moment in time where there's kind of unprecedented travel of dogs between different countries, both because owners take their animals on holidays, but also because of people rescuing dogs from abroad, we are seeing things that we weren't seeing before. And I think Ehrlichia, the same as Babesia or Leishmania, they are diseases that we should consider even in animals with no travel history, for sure.
Okay. And then what about, I mean, we've focused mainly on the dog, because we're considering Ehrlichia canis. And what about other species? I guess I'm talking about cats mainly.
Yes. So cats, as far as I know, haven't been shown to have clinical disease with Ehrlichia. Neither people also do not get infected, or at least do not develop clinical disease with Ehrlichia canis. So it does seem to be a disease of dogs.
Dogs only. Okay.
That's not to say that the cat couldn't get infected, but it's just that clinical disease appears to be very rare in cats.
Okay.
Not the case with Anaplasma, on the other hand.
Yeah, Anaplasma, no. And then, so if we should move on how these patients might present. What are the things that might raise our suspicion? Are they purely clinical signs, or are they, when you start doing your investigations, there's changes that might flag you need to consider it?
Yes, so it can Ehrlichia can present in kind of 3 clinical stages, if you like. So you can get the acute stages of the disease, that can occur within 2 or 3 weeks of infection and lasts for kind of 2 to 3 weeks. And these animals will present with vague symptoms of illness. So it could be fever, lymphadenopathy, lethargy, inappetence. If we run bloods on these dogs, quite often they will present, they might have a neutrophilia or a thrombocytopenia, for example, so they might have some hematological changes. Then they can, if they get treated, at that stage, they can clear the disease. However, if they don't get treated, they may enter a period of time of subclinical disease where they don't have any symptoms, but the organism is still there. And they can remain asymptomatic for months or even years. And then at some stage, they can enter a chronic stage of the disease, which is more severe and can present with kind of immune-mediated like symptoms. So, for example, what might look like an immune-mediated thrombocytopenia. You might see fever, again, similar symptoms to the acute stage of inappetence, just vague clinical symptoms. You might see uveitis. So almost how you would expect a dog with immune-mediated disease to present.
Okay.
But hematological changes at that stage are very common, so thrombocytopenia or even pancytopenias.
But would you, I mean, is it common to, I'm just thinking about, we see a lot of ITP cases, and if we're mentioning that this might be something we need to increasingly be aware of, are we saying that ITP cases, we should consider Ehrlichia as a screening test, if we've got a low platelet count, or do you typically see hematological changes in addition to uveitis, which wouldn't be I mean, you could get a lymphadenopathy and a pyrexia with an ITP, but you wouldn't typically see like a uveitis.
No. Yes, you might see uveitis. The fact that you don't see uveitis doesn't mean that it's not ehrlichiosis.
Okay.
So I suppose the question is, would you screen all your ITP cases for Ehrlichia? And I would like to say yes, but of course, how do you screen a dog for ehrlichiosis? Serology might be difficult in the very acute stages. So it just kind of raises some issues about how would you diagnose ehrlichiosis in the acute stages. And I guess that's the question, that even if you screen, you might get a false negative result in the acute stages.
Yeah. Okay.
Certainly, if you see thrombocytopenia in conjunction with something else like uveitis, and hyperglobulinemia, for example, then I would put Ehrlichia as high in the differential diagnosis. If you see a dog with no biochemical findings, no lymphadenopathy, no fever, and just a very low platelet count, a dog with no travel history, maybe I would think Ehrlichia is less likely.
Yeah, you'd be unlucky in that situation, wouldn't you? It'd be very, and to be honest, as we talked about in some of the other podcasts, a test is only as good as when you use it. So if you start using, you're very likely to get a negative in that kind of case. So why run it?
Yes, exactly. I think you have to use your clinical judgment and look at your clinical findings, but also your biochemical findings, and then make a decision about how likely you think Ehrlichia is in a case like that.
Okay, cool. Which is a seamless link to us talking about diagnosis. And I'll admit, I'm not aware that I've seen a case of Ehrlichia. I like all medics, we may have missed a case, missed a diagnosis, but it's something I've never diagnosed. Or so how would we go about that?
So again, we go back to the very basic principles of diagnosis any infectious disease. So really, we have either tried to identify the organism cytologically, and with Ehrlichia, you might get lucky and see it. It's unlikely that you will see it on a blood smear. Remember, it's an organism that lives in mononuclear cells. You might see it if you smear blood from just underneath a buffy coat, for example. But just bear in mind that not seeing it on a blood smear does not mean that the animal doesn't have Ehrlichia.
Okay.
You might increase your chances of seeing it in lymph node aspirates, for example, in a dog with lymphadenopathy, or splenic aspirates, which obviously are a little bit more invasive, or bone marrow aspirates, particularly in animals that appear to have bone marrow disease, for example, if they're pancytopenic.
Yeah, I suppose when you're choosing to do those samples, though, you have to consider the hematological changes. So doing a splenic aspirate with no platelets, or low platelets, even if you've got a high suspicion, that's something we wouldn't advocate.
That's a big point.
However, we even, I have to admit, I've done FNAs of lymph nodes in patients with moderately low platelets, and sometimes they bleed a lot, but bone marrows, I don't know if you'd agree, bone marrows with thrombocytopenia are relatively well tolerated. So
yes, bleeding is maybe easier to control.
Yeah,
I have done splenic samples in a thrombocytopenic when you've been on call.
Yeah, on Friday at 5 o'clock, just as going, bye Ian, I've just done this, bye. So that's been nice, a nice moment, and maybe why I remembered to mention it.
Yes, very good, very good. It's a good point.
Yeah, but I guess from a general perspective, that's good. It's a good tip to mention that, if you've got a pancytopenic patient where they've got low platelets, you can still do a bone marrow in those patients if you feel there's a clinical need. I mean, you may want to screen for Ehrlichia in a different way, but I guess that's me just covering all other differentials for that. So we mentioned demonstrating the organism. So then you've already mentioned serology, and of course there'll be PCR. So if you just want to overview the aspects of that with respect to Ehrlichia.
So PCR is another way of identifying the organism, but has higher sensitivity than cytology. So again, you can do PCR on blood. Now, thankfully, we have got very good PCR assays in different labs. So it just increases the sensitivity of finding the organism. Remember that getting a negative PCR result does not mean that the organism is not there. It just means that the organism hasn't been detected. So that's something to bear in mind when you're reporting PCR results. A negative does not mean that you've definitely ruled out Ehrlichia.
Okay.
But obviously, a positive result is very, very supportive of active infection, when you find the organism.
And I guess because then there's serology, but serology will take time. So the PCR is going to be more useful in the acute stages.
Yes.
Whereas, as we've talked about with other infectious diseases, in an ideal world, you do the whole profile.
Yes.
But serology is going to be more useful in a patient that you're more thinking chronic.
Yes. However, I would suggest that when you have a high index of suspicion of Ehrlichia, that you do both, that you do serology and that you do PCR, and that if possible, you do quantitative serology. Because although when we're talking about Leishmania, we were discussing the importance of the magnitude of the titer, it's not so clear with Ehrlichia that a higher titer is more indicative of active infection. But there is some suggestion that the titer does correlate with bacterial load to some extent, and also it might help you. So, for example, if you've got a negative titer, when you're highly suspicious of serology, then you might want to repeat it 2 or 3 weeks later and see if you get a positive titer. And also, and this is not definitively proven, but sometimes we do have a question about whether we've managed to clear Ehrlichia or not, particularly in chronic cases where it can be very difficult to clear from the body. And if you see that you go from a high titer to a low titer or even negative titer, you'd feel more confident that that the animal has cleared infection. So it can be a way of monitoring the disease and knowing where you've hopefully got rid of the organism. This is not as well established as it is with Leishmania, but I would suggest that when you do serology, you do get quantitative titers. You can use the qualitative tests, like the SNAP4DX that will give you positive or negative as a screening test. But if you do get a positive and the owner has the finances to do it, there is some value in doing a quantitative serology.
Okay. Right, and I guess just coming back to PCR, it's important just to highlight that it's not necessarily just blood. If you do a bone marrow, you may actually get a better chance of getting a positive result because again, a negative, not seeing it on a bone marrow doesn't mean you've not got it, does it?
No, exactly, and that's a good point. That if you're going to do PCR, it might be if you do have lymphadenopathy, maybe running it on that sample increases sensitivity. And also remember that if the animal is receiving antibiotics, that's going to reduce the sensitivity of the test, so you might get a false negative result.
Okay. Which is another seamless link onto treatment with your mentioning antibiotics.
Yes.
Very good at that. So we've made our diagnosis of Ehrlichia. As you've mentioned, some of these patients, I suppose there's two aspects to it. How do we clear the organism, and then some of these patients present very much like immune-mediated disease. So there's two arms to this. Do we do anything for that, or do we just clear the organism?
So when you see Ehrlichia as an acute infection, it's relatively easy to treat. So in most cases, 4 weeks of doxycycline will resolve the clinical signs, the biochemical findings, and the and clear the organism from the body. And in most cases, it's well established that this organism does trigger immune-mediated disease. So it's thought that the thrombocytopenia in most cases is immune-mediated, but obviously secondary to the organism. And by clearing the organism, the thrombocytopenia resolves in most cases. So most of these animals will not require immunosuppressive treatment. And in fact, we would discourage using immunosuppressive treatment with any infectious disease. The aim would be to
clear the trigger.
Clear the organism first. However, in chronic cases, it is a lot more difficult to clear the organism. So if you have an animal that has lived with Ehrlichia for months or years, and for example, it's got to the stage of pancytopenia, you do a bone marrow sample and you've got a hypoplastic bone marrow, hypocellular bone marrow. Those are difficult cases, and sometimes for that bone marrow to recover is extremely difficult. So even trying to get rid of the organism will not necessarily resolve those changes.
Okay.
And it's a lot more difficult to clear Ehrlichia with antibiotics when you've got a chronic infection than it is with an acute infection. So the prognosis is very different in an acute infection than it is in a chronic infection. And I dare say that in the UK, we probably see more chronic cases because we see some of these rescue dogs that may have had the disease for a long time. And by the time we see them, they're not in the acute stages of the disease.
And of course, may have more than one disease as well.
That's a very good point, actually, because when you diagnose Ehrlichia, just bearing in mind other concurrent diseases, and particularly in animals that are not responding to treatment, just think, could they have something else? Could they have Babesia? Could they have Leishmania? Could they have Borrelia? Could they have Anaplasma? Admittedly, Anaplasma and Ehrlichia have very similar treatments, but just bearing in mind the possibility of co-infection.
So I guess if you've got an Ehrlichia case, a chronic one, you may have to accept it doesn't respond, but it may also not be responding because it's got a coexisting disease. You may have already tested for, done a screening for all of them, but as we know, no test is perfect. So if you've got a poorly responding case, don't be afraid to recheck, Leishmania serology, I guess.
For sure.
Yeah.
I agree completely. I think just because this say for example, this rescue dog is positive on a SNAP4DX for Ehrlichia, just bear in mind you're not wasting the client's money for screening for Babesia and Leishmania as well, because co-infections are so common.
Yeah. And what about, you've mentioned doxycycline. Are there any other drugs that have been looked at as alternative treatments, or is it still a few people recommend?
So tetracycline seemed to be the best treatment for Ehrlichia. There is very poor evidence of efficacy with any other drugs. Some people mention imidocarb, concurrent use of imidocarb with doxycycline, but that's really not very well established unless there are co-infections with other organisms, for example, Babesia canis. But for the treatment of Ehrlichia, we don't really have very good alternatives to doxycycline.
To doxy, okay. And then, you've already mentioned, after 4 weeks, you get resolution of biochemical changes. I presume that, is it clinical examination, biochemical changes, or do you do any more PCRs or anything like that when you're monitoring response to treatment?
Yeah, so normally, particularly with acute infections, they normally get better very quickly. Sometimes just within a few days of starting treatment, they start improving. And you would expect the thrombocytopenia and hopefully the hyperglobulinemia to have resolved after the finish the course of treatment. If you wanted to recheck to see if the animal has cleared the organism, then you could do that with a combination of PCR and serology. Now, you wouldn't want to do the PCR straight away after finishing the course of antibiotics, because we've said that the doxycycline will inhibit your PCR results. So you want to wait at least 2 to 3 weeks after finishing the course of antibiotics to repeat the PCR, just to make sure that the antibiotic is out of the system, but also that the animal has cleared all Ehrlichia in the bloodstream anyway. So you do want to wait a little bit. And also bear in mind that titers will take a bit of time to change. So if you repeat serology, you want to give yourself a few months to see a difference in titer. In an acute stage, you would expect that most dogs, if they've cleared the disease, will become seronegative within a few months, up to a year. So it will take a little bit of time for titers to change. But maybe you could repeat PCR and serology a couple of months later and see where you are. I think the greatest difficulty is when you don't get resolution of the thrombocytopenia after a course of doxycycline. And I think that's where we get lots of calls asking, what do I do? I've given 4 weeks of doxycycline, and the dog is still thrombocytopenic. What are the options here? I think, and that's very challenging, because at that stage you don't know if it is the organism that's triggering the immune-mediated disease, or the organism is gone and you're just dealing with an immune-mediated disease then. those are difficult questions to answer, and I think you need to look at each case.
I mean, I generally don't know the answer to this question, and you may not, but I'm just thinking about those pancytopenics. If they're chronically infected, are there chronic changes in the marrow that are irreversible?
Yes.
I don't know.
Yes, there are.
Okay. So you might just not get a response to those because it's so chronic that the marrow's damaged.
Yeah.
Okay.
And then what do you do in those cases, and how do you approach them? Do you approach them trial immunosuppressive treatment if you can be sure that you've cleared out the organism, and that's the difficulty. How can you be sure that you've cleared the organism? I mean, the best you can do is try and see if you can get a negative titer and a PCR negative result,
or repeat the bone marrow and do a PCR on it.
But as I say, those very kind of chronic cases are really difficult to manage.
And again, this is me I haven't thought about this until this very discussion. I mean, people use things like, lithium is we've used for red cell aplasias and things like that. Is that those kind of therapies, GCSF, if there's neutropenia, have they ever been used in these cases?
I'm not aware of clinical trials. Even with the evidence behind lithium is fairly.
No, I'm not saying it's there's a limited case studies on it, but if you've got a difficult case,
I think there are things that could be worth trying.
But at a very end stage, not part of your standard treatment. Okay, cool. Well, fantastic summary as ever, Patricia. We hope everybody who's listening has found that useful. As before, just a quick recap that we've got a bit of a back catalogue now of Davies Out of Hours podcasts. We've got medical discussions, but we've also got surgical, physiotherapy and cardiac podcasts that you're available to download, or if you want to contact our marketing department. Thank you once again to Patricia. I think we've got one, because we've got mycobacteria to do, excuse me, but I think the next one I'm doing with you is diarrhea. Is that correct?
Oh, that's right, yes.
Yes, so I guess we'll touch base tomorrow to record that. And to everybody at home, stay safe.
Thank you very much, and stay safe.